Namaskar, hello and welcome to this very special series, The Future of Healthcare podcast with Dr. Surbhi, and then subsequently with a host of other doyens and eminence in the entire enterprise of healthcare. And the whole purpose behind this Future of Healthcare podcast is that Rethink India Institute, along with Arogyam Institute of Integrated Medical Sciences, has been conducted the Future of Healthcare forums across on a set of divergent themes, cross-cutting, intertwined themes, anchoring into the civilizational wisdom, civilizational healthcare practices of India, from the yogic traditions to the most modern advances in medical sciences. And somewhere or the other, the focus has been on how to create a very robust public healthcare system which is efficacious and most importantly affordable. And the philosophical twist which we want to take it out here is that the human body is an integral whole, and it has been designed by Mother Nature to subsist and to remain nirog, freedom from disease for a good 100 odd years. And that is the philosophical foundation from Bharat. And if any transgression happens, if any disease or discomfort happens, it should be addressed and redressed at the very primary and the preliminary level itself, uh, without letting it cascade to higher denomination treatments. So you can see on the backdrop, a host of themes are out there which we intend to discuss first and the foremost with Dr. Surbi out of her elaborate experience into the medical field, both as a clinician and as a medical administrator, and also as someone who who has a very unique inroads into the Indian traditional medical practices, and also the other metaphysical planes for that matter. And the whole focus of Dr. Surbi has been like how the psychosomatic ailments do affect the physical portion of it. There is an entire science of it all, that from the Annamay Kosh to the Anandamay Adhyatmic Kosh, that is on one layer, and then how to treat it, how medicine also affects with the strength of the mind, so and so forth. And we have been covering a host of these issues in the healing hour, in the medical hour, and so and so forth. So, Dr. Surbi, today's purport as a maiden edition of this Future of Healthcare podcast, where we say that efficacy, affordability, and accountability. Because we all are witnessing out here that despite such a huge growth into the formal medical establishments, there is a huge lack of accountability somewhere or the other. That whether a particular procedural prescription has to be really given it across or not, and there is not very much of cross. I would say relationships, a kind of a audit for that matter. A lot of quality aspects. You have worked on quality in a big way in some of the most corporate hospitals for that matter. So today's focus of this Future of Healthcare podcast is that how can we balance the agency of an independent uh, who is independent of all kind of inducements which are generally prevalent, though MCI tries to put them across under scanner under the ethical guidelines, so on and so forth. But the independent doctor on record, with whose incentive structure is entirely different from that of a healthcare establishment, the enterprise of healthcare, and how the continuity and convergence of care can be brought about. That, like, the whole institution of doctor on record is something which we would really like to discuss out here, because in any of the courts if we go, we need to have an advocate on record who remains all through the court proceedings, and the litigants can invite as many as seniors, diverse seniors, to argue their cases. But there is some doctor, some advocate on record, which is a legal requirement, who actually guides you through the whole filing process and so forth. So, Dr. Surbi, over to you. That what do you mean by a doctor on record out of your own personal experience? And then we will go to the next question, that how both an independent doctor on record and the entire enterprise of healthcare from the pharma shops to the pathological establishments to the procedural delivering healthcare uh, establishments, so that how a very optimal balance can be struck at. Over to you, Dr. Surbi.
Namaskar. Greetings on the maiden episode of the Future of Healthcare podcast. And well, this is a very important, you know, discussion which we are, delving upon. That healthcare as a sector, healthcare as a domain, you know, it is a profession. We say it is one of the noblest profession, the noblest professions. Teaching and healthcare, comes into that. We say that a doctor is next to God. So it is a huge responsibility on the shoulders of the healer, the physician, the doctor. And, you know, reaching out your treatments to the larger population, there are so many factors and attributes which create a efficacious healthcare system. Now, if I say from a patient's point of view, a patient is a person who is afflicted with a certain healthcare condition or a disease or a problem, healthcare problem, and he's looking for care. Now, if we categorize the healthcare problems or diseases, primarily there are primary problems, the secondary healthcare problems, the tertiary healthcare problems. So the I am just trying to build the background here and trying our viewers to understand that how the agency or the need or requirement of a doctor on record comes. And it is it is a very deep narrative in itself, that a patient, when he's having a certain healthcare condition, say for example, a 65-year-old lady having varicose veins. We know varicose veins is something, when the veins are protruded, and it leads to a lot of pain on walking, and often found in elderly population. And how now, how the patient is going to approach the healthcare problem, how he's going to reach the doctor. So this mind map, this flowchart diagram, which if we understand, we can delve deeper into the doctor on record concept. And a doctor on record, if I say, is a person, a professional who is committed to the patient's care right from the point of contact, when the first point of contact is there, when the patient is hitting the clinic of the doctor, the diagnosis is being made, a provisional diagnosis, a differential diagnosis, and a final diagnosis. In our AIMS pedagogy, we really lay a lot of emphasis on the differential diagnosis even. So reaching the diagnosis is in itself a very critical part of the entire healthcare delivery, because we say well diagnosed is half the cure done. So once the diagnosis is done, then the treatment is ongoing, is started. Now, this entire path, when the patient is reaching the doctor that receives the treatment, then the care compliance, the caregiving by the family members, and if a hospitalization or any procedure is needed, then the patient is referred to the hospital facility. So the doctor on record is one who is a nodal person, in charge, who is committed, competent, connected, and who gives end-to-end care, which we say seamless care. So even if this patient is going to the hospital and getting admitted, the doctor on record is coordinated with the various, specialists in the hospitals, the doctors, the caregivers, and the stakeholders in this path to ensure seamless healthcare delivery. Now, this is a unique concept, and which I feel like we have the legal advocate on record who advocates and fights for the plaintiff's case, and till the very last mile. That concept is something which is really needed for efficacious healthcare in our country. And doctor on record is some kind of a agency which is balancing all the various specialties, disciplines, and coordinating them and providing the holistic advice to the patient,
Dr. Surbi, I would just like to come over here. Like you have really given a good primer out here. कि क्या ये सब जो बहुत बड़े बड़े मल्टी बिलियन आई वुड से मल्टी स्पेशलिटी सुपर स्पेशलिटी हॉस्पिटल्स doesn't this very aspect of converging care is met out there? What is the need of a doctor on record in the I would say upcoming India's medical health system?
Yes, I would really say draw an example here, an analogy here from the NHS system of the United Kingdom,
Mhm.
where they have a very efficient backbone and spine of GPs, you know. You see, there are two things needed. One is that who is the doctor who's the first point of contact? Who is the doctor who is listening to your entire history, taking the detailed, physical history points, environmental history, occupational history, social history, family history, genetic history, the entire
So is
history
this a
point are
very
being called out.
integral? So is this also an integral part of any healthcare administration? These history part, what you are talking about?
You see, history is the very important, most important tenet of diagnosis.
Mm-hmm.
And it's very often found that we doctors are doing symptomatic treatment. If a patient is hitting the clinic due to paucity of time, due to overload of patients, a lot of fundamentals of clinical decision making and clinical treatment guidelines are not being met out.
Okay,
As
okay.
a result, the holistic, wholesome diagnosis is not being arrived at even. And
Mm-hmm.
this is something which is leading to a lot of medical, I should say, mismanagement, or even for that matter, negligence. So it might not be intentional, but the protocol has to be followed. And it has paramount effect and impact on the patient's treatment. This, and in my personal journey observation, I have found that history taking often guides you it does the homework of about 70 to 80% of your diagnosis.
So it is just like the software acquisition cycle, the SRS, what we talk about in the software engineering, that you
Mhm.
have to really go deep into the problem collection, and coding is just a small part of it all. It's all about the specification gathering. So history taking in the medical parlance is all about formulating a patient profile per se, and then hitting on to
Absolutely.
diagnosis and treatment protocols,
And
right?
that is, yes, yes, very much. And that is where the concept of the family physician or the doctor on record or your general practitioner comes into play. Your family physician, your doctor on record is someone who knows you, has your medical files, is in touch with you for your past medical problems as well, knows your family conditions, your environmental conditions, your social conditions, and is able to correlate your disease to your current state of being. And we know disease, as the WHO defines, is not merely, absence or um, it is not merely just a disease which is absence of health. It is complete. It's completely disease. If you go to the etiopathogenesis of it all, there are psychosomatic factors, there are mental factors, there's physical factors, there are infectious factors, there are environmental factors, there are social factors, and genetic factors. So, in a sense, in a nutshell, what I'm trying to say is that the disease paradigm progression diagnosis comes from efficacious history taking. And
Okay.
this is something, you know, I don't spend less than 15 minutes in a history taking with my patients.
Okay, okay. The
So,
joke, the usual joke across the cities that you spent 45 minutes commuting to the clinic of a doctor, and 90 minutes you keep on waiting, and the doctor just gives you just 5 minutes. And Dr. Surbi, you are talking that you take 15 odd minutes to really create a patient profile by taking his medical history, occupational history, environmental history. I think Uh,
You see, you
what kind
see,
of a healthcare we are delivering that way
you
otherwise?
see, actually, the situation is that hospitals are overloaded
Mm-hmm.
with patients of all genres. Their primary care, secondary care, tertiary care. Everybody is reaching the hospital,
Okay,
especially in
okay.
the metropolises. The there's abundance of corporate multi-specialty hospitals. So a middle class typical family member is going directly to the hospital for even the smallest healthcare problem in the wake of getting the best healthcare advice. And
Oh, ho, 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 ho.
going to a specialty doctor whom we say a specialist, and the specialist is overloaded with so many cases, especially if you see the tertiary care hospitals like AIIMS Delhi, or even the OPDs at AIIMS, and the various other government hospitals. They're really overloaded with patients. Now, this calls for a lot of thought, a deeper dive into the healthcare ecosystem, how it is coming from the village, from the district, to the capital, to the state capitals, to the state cities, to the Delhi NCR and Bangalore, Kolkata, Mumbai kind of megapolises. So the
So
entire
medically, you want to say that not all patients need a hospital care for that matter.
absolutely not. Absolutely not. You see,
Mm-hmm.
that is where a primary care practitioner comes into play.
Mm-hmm.
And if you see our primary healthcare centers, PHCs, CHCs, DHCs, if they are delivering the healthcare well, you know, you see a general practitioner or a primary healthcare physician has a very critical role as well in the populace, because you see, one, patients are scared of going to hospitals. If you see the psyche, a hospital is a place where procedures are performed, where IPD is there, some OPDs for tertiary care problems where multiple departmental specialists are sitting together. But the concept of GP, today doctors don't want to become GPs.
Mm-hmm.
The very aspiration and need mismatch in the country is rampant.
Mm-hmm. But structurally, you mean to say that a doctor on record who can be called as a GP or a family physician or a community physician, he or she is able to arrest the progression of any disease at the primary and preliminary level
Well, you
so that
see, it is very,
the
very scientific. It is very, very
Mhm.
scientific. If you are measuring the blood pressure, if you're measuring the vitals, if you're having a preventive healthcare program, with your GP, uh, you will not miss the diseases late detection.
Mhm.
It comes in oncology, it comes in all the lifestyle disorders, diabetes, hypertension, the cancers today which are happening, screening. And then once it is diagnosed, the maintenance part of it, the
Mhm.
continuous monitoring part of it. And we need an integrated healthcare system. What I mean to say is that medical, of course, medical sciences is a discipline in itself which involves teamwork. It cannot exist in isolation. So
Okay.
every healthcare professional works in teamwork with the entire sector industry per se. So that is how we build the enterprise of healthcare. For a
So
sound,
primary and preliminary level of medical treatment is not inferior, you mean to say? Because generally in the Indian psyche, we all want to become some ace, some top, some prominent ones. But if in the efficacy desk we put it across, so I think the primary or the preliminary physician is the core of it all, because the human body is a perfect machine for that matter, and if there is some ailment here and there, if at the primary preliminary level it is detected, early diagnosis and timely treatment, so it
absolutely,
and that
absolutely.
should be the philosophy of the entire public health system for that matter.
Absolutely. Because you see, there has to be a system of things. There has to be a system where nuts and bolts are, the entire model has to be in cohesion with one another. So
Mhm.
the ideal flow diagram would be that a patient goes to a general practitioner or a primary care physician who takes the detailed history and presents, prepares the summary, formulates a diagnosis, starts the treatment at his level, his or her level. In case the problem, according to her own judgment, here comes an important point. GPs have to be good referral points as well. They
Mm-hmm.
have to know the thin line that where the case has to be transferred, what we say the case
They
transfer.
should not keep it with themselves, with their
Yes.
limited understanding, though they are
So,
critical, but they
yes,
should have that power like a traffic policeman. Ki, okay, you go here, you go there, and you go here.
absolutely. So
Hmm.
the right kind of that ego should not come into the play.
Hmm.
So if the specialists have an ego, the general practitioner is also having an ego. This
Hmm.
is what is the obstacle. So refer
Hmm.
the patient rightfully at the right point in time, but 75 to 80% of the cases, the GPs can handle the primary healthcare problems, ailments at their level. And
Hmm.
this leads to efficacious healthcare delivery, improvement of healthcare indices, and so much of prevention of complications. The
Hmm.
specialists are important. Their role is very critical as well.
Hmm.
But their role should be in the higher tertiary cases where it needs that kind of a care management,
Doctor, would you like to give a
procedure,
couple
surgery.
of case studies, couple of examples? For example, a patient comes to you, you do the initial workup using the localized pathological setups and things like that. And the moment your clinical decision says, oh, this person needs now further workup in an IPD facility or establishment, you have routed them over there. So give a couple of examples so that we can understand as to how the GP has to be the first touch point, a very go-to kind of a person, and then the GP, the doctor on record, forwards the patient to higher care, secondary or the tertiary care for that matter.
Absolutely, absolutely. You see, if you see, I will give an example. In the case of one of my very revered patients, had a history of chronic cough,
Mm-hmm.
for more than about 6 months to 1 year. And
Okay.
the patient came with that kind of a history, and sitting on it with so much of cough and discomfort. So, of course, I got the blood test done, the first line of investigations, which are there needed. Say, for example, the Mycobacterium tuberculosis testings, the various blood tests, for infections, and all the kind of blood profiling. I did that. And when they were reporting some kind of an infection in some kind of inflammatory condition, I recommended the patient to go for a CT scan of the lungs. And the patient complied, got a CT scan done, and lo and behold, the diagnosis is clear that it was an interstitial lung disease. Now, this kind of a condition, this diagnosis was being missed because the patient was scared to go to a hospital.
Okay.
The
Okay.
patient was scared to go to a hospital,
They kept on lingering. Yeah.
taking cough suppressants, self medication, just to address the asymptomatic treatments, but was scared to go to a hospital. Now, this is where the doctor on record comes into play. And we know in ILD there are a lot of exacerbations, which we call the accentuated episodes. So I immediately referred the patient to the AIMS Pulmo department, where the respiratory medicine HOD there took the patient into complete care, and the patient stabilized.
So that's where the interplay of a GP and the enterprise of healthcare comes into play. That up to that preliminary diagnosis level, you were a
Absolutely.
critical care handler. The moment you found that now this is what, you referred the patient to the higher center and under the care of a specialist and the super specialist, and then the
Whom
patient
I
got
was in
treated.
constantly touch with, whom I
Okay.
was in constantly touch with,
Okay. For care
as
compliance perspective.
a compliance perspective, as per se the progress of the patient, the hope just to check that the patient is complying with the hospital guidelines
Hmm.
and instructions. There is no LAMA, that is leave against medical advice. All these factors need to be.
Because in the Indian conditions, patients are generally aloof about their own healthcare, and they get frustrated with the larger complications of the. Uh,
Indeed, indeed.
hmm.
So this is, one example I have given in pulmonology. Similarly, in gynecology, often I come across patients who are having fibroids or, some kind of prolonged menorrhagial conditions, menstrual problems. So, you know, a gynecological visit is something which is scary to the patients. Now, this was a lady who was a menopausal lady. premenopausal, just in the age group of 46 to 50 years, and she had prolonged bleeding for about a year and a half, and she was just ignoring these problems, taking painkillers and trying to just tide over the problems. When I diagnosed, I got an ultrasound done. When I met the patient, I got an ultrasound done, found that there was a fibroid, and this could be a malignant even, which needed to be ruled out because the history was prolonged. The lady was in that age group. So I then coordinated her case with an obstetrician and gynecologist, with a gynecologist who was close to her area where she was residing, and got the surgery done. You know,
Mhm.
the importance of the surgical audit comes. This decision has to be taken by the GP and the surgeon in coordination. So
Mhm.
I primed the gynecologist that look, this is the history, to save time, and to have speedy treatment. And this decision that yes, you should go for a surgery, I gave her this
And
and
during the same
referred
surgical
her.
intervention, the sugar levels got detected, the BP issues came through. So that's where GP comes into play. Uh,
Absolutely, absolutely. Because you see, there is a lot of importance of all-round health treatment, from multi-specialties point of view. So during the surgery, the blood pressure needs to be maintained for the anesthesia. The sugar levels need to be maintained, all that. So in this, the role of the physician is important. And often the treating physician, your doctor on record, is someone whom the patient confides in much more because of the constant past history of, going to the doctor, trusting the doctor. So there's some very, very fine points. In fact, during my this experience, for even small questions and queries which the patients had during the hospital tenure, they dialed my number and did not dial even the doctor on duty's number because of the comfort and this leads to speedy, seamless care convergence. This is something which I've experienced, and patients are willing to pay. The payment is not the problem often, but they want quality, seamless care, complete care. And from the ethical point of view as well, it is so rewarding from the gratifying point of view when the patient comes out with a gleeful smile and with a healing demeanor. It is truly that is the success of the healthcare system, the doctor on record.
mhm. So it is pre, during, and post, even at the procedural post facto care compliance, the role of a
True.
GP is so much profound over there.
Indeed.
Mhm.
And also I would like to say here that the enterprise of healthcare, when we're talking of the entire healthcare system, you know there is the role of every layer. If the doctor on record is doing his duty well, the specialists or the surgeons are doing their duty well, the emergency department is doing their duty well, and they're all integrating. Today there's a slight factor which we all need to work upon is the D2D discussions, the
Mhm.
doctor to doctor, some kind of systems we need to work around so as to not be in our silos of ego and, what should we say, individualism, but go out and, create an atmosphere of D2D discussions, doctor to doctor discussion. This would help the patients a large deal. And this should be not just between a generalist and specialist, but between the different specialists as well. And that's why the doctor on record comes into play. That if the patient has a multi-systemic problem, going to a cardiologist, going to a neurosurgeon, going to a gynecologist, who is going to integrate the entire advice? And very often there are certain queries or questions for the overlapping areas. You
Mhm.
know, so डॉक्टर ने कहा है कि ये नहीं खाना है, उन्होंने कहा है कि ये कम खाना है. There is a doubt in the patient's mind.
So you mean to say that there are three super specialists, they have their own individualistic prescriptions, but there is no central agency to converge them all together. And if there is some doubt, going back to those super specialists and taking their view about the convergence, ki dropping someone, picking some medicine, something like that. So there is
Yes.
no agency of that sort, a department of convergence of care in these super specialty hospitals, Doctor?
True, true, true. That is why this is where I'm quoting the NHS, you know.
Mhm.
So we need a very strong spine of this doctor on record, and which should be institutionalized. It will not work with just one or two GPs here and there. We
Mhm.
need an entire army of doctors on record who will be coordinating with the hospitals, the tertiary care centers, the specialists, and leading to continuity, convergence, efficacious, affordable, and accessible healthcare, health for all, which
So
we
now
say.
India, when India has got such a large plethora of medical education system, a much larger number of doctors are graduating from 800 odd medical colleges of the country. So perhaps this is quite a ripe time where our public health system, whether it is publicly funded or it is privately funded, because human body is the same, the entire national health system has to become a kind of a continuum where we have a majority of touch points as GPs, as doctors on record who are available here, there, everywhere. And these doctors on record, this is the kind of a perspective which Dr. Surbi is trying to envisage the future of healthcare of India and perhaps across the globe, because whatever challenges we have in India, the scenarios, if it works for India, it will work for the whole world, like the UPI or so. So a doctor on record has to be empowered upon, he has to be given a kind of that agency over there with D2D telemedicine helplines, what Dr. Surbi is so very passionate about. And then we already have a chain of diagnostics in terms of blood work, urine work, or sputum work, along with the imaging. So these are
True.
standalone diagnostic facilities which are not directly associated with any of the procedural hospital. While hospital or establishments do have everything under one roof, but patients are quite comfortable because not everyone is covered under very generous schemas like CGHS or the heavy corporate kind of
Insurances.
insurances and all that stuff. And there is always a risk of getting these financial instruments being abused. And in a large country like ours, even the Arogya, the government's flagship Arogya Bharat insurance scheme, there are a lot of incidents that unnecessary surgeries are happening, unnecessary procedures are happening, because everything has to happen in an accountable fashion. Now, when we are even seeing the Ram Mandir chandas also being robbed away, so the human ethics, so the best strategy is to have multiple points of control, like a doctor on record, like a standalone diagnostic chain, then a procedural hospital, so that the patients have a leeway. Okay, we have to get this procedure done at a hospital one, or a procedure to be done at hospital two. We have to negotiate the rates. Doctor Saab, because you happen to be a medical administrator as well, what kind of financial decision making come into play, and how the GP helps in zeroing down on a particular hospital for
Yes,
a
yes.
procedure? Yeah.
You see, every IPD procedure has a bill estimate to it. The
Hmm.
finance department of the hospital prepares an interim bill, a estimate, a quote, an interim bill, and the final bill. Now, in the medical administration, it is very clearly to their cognizance that this would be the approximate roundabout incurrence of cost to the patient for this procedure, so and so procedure or surgery. Now, this cost is often not revealed to the patient a priori, in entirety, generally speaking, in all the hospitals, corporate hospitals especially. So many of them are cashless or insured. So they say, okay, our insurance company will fund for it. Now, in the finance part of things, those patients who are going to the hospital for some procedure, the GP or the doctor on record inquires about this medical billing, like I do for my patients. I get a quote a priori, inform the patient that look, this hospital is charging you this much. These are the doctors who would be doing your procedure. And if you're comfortable, then you should go ahead. And these doctors are, in my opinion, in my line of treatment, of course. I being a GP, I discuss with the surgeons or with the specialists that this is the treatment according to the AIMS pedagogy which we want to implement, protocolized medicine. And that protocol, those doctors who are in mostly, I mean, we align to that, and the costings which comes to that is informed to the patient. The patient agrees and is prepared, and then goes to the hospital for the procedure. So it doesn't come as a shock. On LinkedIn, very often I find articles of patients going to various hospitals, corporate hospitals. I would like not name, but every third day there is some report which says, "Oh, I was fleeced. Some cost was given to me which was exorbitant,"
Mm.
and so
It also prevents the loss of trust in the entire medical system per se. The
yes,
intervention of a trusted doctor on record, it helps. Uh,
it helps definitely.
mm,
And when I'm recommending a patient to a doctor, I am singing praises about that specialist, that surgeon, assuring the patient. In fact, in one of my cases, the patient had a lot of anxiety
mhm,
before the surgery, because surgery, of course, वो कहते हैं ना कि जिस पर बीतती है वही जानता है. So when the patient was being administered anesthesia, her blood pressure used to spike like anything. And then I had to counsel the patient repeatedly 2 to 3 times. The doctor is a trusted one. You are in the safe
mm.
hands. Please do not feel anxious. Please just do your deep breathing and you'll be fine. Now, this kind of an assurance built the trust in the entire ecosystem, isn't it? And that helps. That helps the entire healthcare ecosystem per se, the patient support and cooperation per se, and the patient to get healed by undergoing the procedure without any worry or friction.
Doctor, we would also like to listen about your personal experience. You are a doctor on record for your family also. And
Mhm.
you talked about some secondary level cases like hysterectomy or something like that. But then the real, I would say, the real tertiary cases of neurosurgery and laparoscopically removal of uterus and things like that. And you somewhere got into a case, very close family member of yours, where you got the oncological treatment done at three different super specialty institution. Now this is quite interesting to know because generally every super specialist hospital has got all kind of paraphernalia, but why it happened, what was your decision making parameter, we would really like to know about it.
So this is the case when a family member, of mine who is geriatric age group, 70 years old, having a brain tumor, which was diagnosed to be meningioma, needed a neurosurgery. So my AIMS professors operated on her, and
Hmm.
she came out of the neurosurgery, and just when was recovering, diagnosed to have a uterine cancer, cervical
Hmm.
cancer, which was grade 1 and malignant. Now, just a surgery 1 month ago, after another month, another surgery to be done. So the tumor was resectable, identified, and so the hysterectomy had to be done basically because it was quite, needing that due to the according to the surgical protocol. So a radical hysterectomy kind of a procedure. Now, first of all, this diagnosis of the cancer malignancy had to be done through a biopsy. So that would need an anesthesia. So one anesthesia in the neurosurgery, second anesthesia in the biopsy, and third anesthesia in the gynecological surgical procedure. So three anesthesias in totally in a 70-year-old lady. So this is something which is quite hard to, endure. I mean, from all geriatric standards. So first of all, I intervened here and requested that the biopsy and the gynecological surgical procedure should be done in the same anesthesia. And this was found to be done at one of the corporate hospitals in Delhi where the frozen section was there. And so
Mhm.
it was done. In one anesthesia, two surgeries were done.
So a doctor on record is
Biopsy.
more like a medical activist herself,
Yes,
who
yes,
is
yes.
competent and who is connected. So you rang up so many people just to find it across,
That the
and
frozen section is there in this hospital or not. And
Mhm.
then once this was done, this procedure was done. Now the
And your
next.
concern as a GP ki bhai would a 70-year-old person would survive a neuro, because neuro people are consider they have done their job, and now
True.
the gastro oncologists they have to
Gynec
be
oncologist.
sensitized upon.
Yes.
Uh, कि भाई, would you be really giving them two anesthesias back on back?
Absolutely. So this is
Hmm.
the critical problem. And with this, the procedure was done successfully. Now the next step was the chemotherapy.
Hmm.
So of course, I mean, protocols are to be deployed in the best possible manner. So I ensure that the NCCN guidelines are being deployed. So chemotherapy I got done from another hospital where, I was assured that the protocol, because you see chemotherapy medicines are quite, they are hard on the body. You see, these are very heavy drugs. And in layman terms, if I say, there's a lot of hair fall, there are a lot of digestive issues, the body is under toll when you get chemotherapy. So this is something that for the patient, a 70-year-old who's just endured a neurosurgery, how she would endure the
Hmm.
chemotherapy, diabetic, so many other things.
So that empathy of a GP comes into play at every step of treatment.
Absolutely. So
Hmm.
guiding her to the best care, all-round care, so that the chemotherapy is
Retrofitting the
successful.
house for a chemo kind.
Absolutely. Indeed.
Mm-hmm.
So this was done. Then now the next step comes for the radiation,
Mm-hmm.
radiation oncology. So now where the sandwich protocol, that chemo sessions have to be sandwiched with the radiation. It should not be that the chemo goes on endlessly and the patient is so tired or fatigued,
Mm-hmm.
or the general well-being goes down that is not in a position to take the radiation therapy. All this has to be taken into account. So who's going to fight for you? Who's going to, work for you? Who's going to discuss with all the
So the
various
three stages of the treatment at three hospitals that was coordinated by you. This is just one of the case studies which tells that the kind of criticality what a GP, a doctor on record, actually bears. Dr. Saab, this was more of a family matter, a labor of love. But a doctor on record in the contemporary time faces the twin paradoxes that the
true.
entire pyramid of incentives is reversed for all the this grub work. Do the doctors on record really get handsomely paid? Do the people have the intent to recognize the contribution of the doctor on record, apart from the personal family matters, but professionally? Because people will pay lakhs and lakhs to a surgical operation, but if a doctor on record comes and ensures that everything goes hunky dory, everything goes in a very profound fashion,
Yes.
accountable fashion. So, what are your views about that?
So I would say that a system needs to be devised.
Mm.
Currently, there is no such system which recognizes the effort of the doctor on record, how many doctors on record we have to institutionalize the system. That is why I said this concept needs to be institutionalized. We
Mhm.
need to recognize this placeholder, this role of a doctor on record who is your one man army, to coordinate with all the forces, the army, the navy, and the
Okay,
air
the
force.
integrated defense headquarters.
Yeah, so he's your chief of defense staff who's integrating, or you can say, well, the
Mm.
CDS is of course the HOD, but we are saying the nodal person. So
So there can be a handsome sign-up fee for such a doctor on record for taking on the
yes,
entire
that can be there.
spectrum
That should
of
be there. That should be
but-
there ideally, because we have to have a system. That is why the doctors also need an incentive, a reason to do so much of hard work. Handling 20 calls a day now for this gynecological patient whom I got the fibroid for the surgery done. At least 20 calls a day, coordinating with the specialist, small queries, because you want excellence in every parameter. The patient
Mhm.
satisfaction is not just enough. We want patient delight, quote unquote.
Mhm.
So this is something which is achieved through micro to macro parameters. How are you going to achieve that? There needs to be incentive structure. So a system has to be devised wherein this kind of a facility or this kind of a process has to be recognized that it's there in
Mhm.
the system, and it needs to be rewarded. It needs to be, that a fee has to be attributed to it also.
And apart
So
from the financial aspects of it all, at every stage of treatment, whosoever super specialist or subspecialist treats that patient,
true.
there has to be some trigger in the system that the doctor on record of that very patient is informed at every
Yes.
stage of it all through a
That
systemic approach, so that the
yes.
agency of the doctor on record gets bolstered कि भाई मेरा patient है, and so he or she can intervene, keep on intervening, has an interest. Otherwise, you come to the doctor's clinic, get the initial diagnosis or initial benefits, and then you uh, get lost out in the whole, I would say, maze of it all. And then when something collapses all over again, then you return it back. So a closure system has to be out there in some way.
Absolutely, absolutely.
Mhm.
So this is important, that the entire stakeholder matrix, the trust, the transparency, the confidence of the patient and the doctors amongst themselves, the team has to work as a unit together, entire team
Mhm.
of doctor on record. And in fact, I would give you an example. There was a patient here in Uttarakhand who had his child had typhoid and an ENT problem, both together with. And so the patient was in another town in Kashipur, and I am in another division of Kumau. So how I coordinated with my network, with my doctors there in Kashipur, got the best pediatrician to attend to that because the child needed IPD, IV drugs because it had accentuated to that level when the patient encountered, when the patient came to me. So this kind of a care convergence, where
Mhm.
the best protocol is being implemented. The ENT conditions I had discussed with my AIMS ENT doctors as well, and the doctors on ground were confident that they are working according to the best protocols, and they were all delivering as a unit, as a team, and there was no issue of any kind of a soft issue or any ego or anything
Mhm.
whatsoever. So that teamwork, the child recovered, and so this is something example of doctor on record or teamwork, where specialists, super specialists, generalists from all hues and strata are coming together to deliver excellent healthcare for health for all. Patient is comes first. That is the central
So
tenet of
somewhere or the other,
doctor.
a doctor on record also ensures that the patient remains disciplined. He or she doesn't go forum shopping. Like in the judicial term, it said that people go for forum shopping on this bench or that bench, because the core procedures, the core grub work, the three-fourths of the whole process of history taking, of formulating a patient profile, of taking differential diagnosis from multiple super experts, so and so forth, it needs a kind of a diligent homework to be done before a case can really be fought at the secondary and the tertiary level. And as Dr. Surbi said, that 80 to 85% of the diseases and discomforts can be tackled at the primary and preliminary level if they come well in time. And even if it is a close to emergency, the doctor on record has the agency to put a kind of a stop gate arrangement and then refer you to the really trusted network and the overwatch of a doctor on record, because he or she has the incentive of getting the patient healed up who is close to his or her vicinity. So that incentive helps an overwatch, a kind of an internal audit over the larger hospital malpractices, if at all they are. There is some insider who can really talk for you in medical terms. The patients, like the financial insurance you do, that is on one side of the story. You also do a kind of an expert insurance, someone who has the agency to really talk in those medical terms to other specialists in the fray. Yes, there has to be a structure of incentive sharing as to why people would be giving up their very refined medical opinions for free. Imzonians are a different breed altogether. That the Imzonian Grand Round, it keeps on solving tertiary level cases on a routine basis just out of their academic curiosity. But then for a larger, stabilized, really efficacious, affordable, and an accountable healthcare system, the incentives have to be properly mapped, monetized. And I think NMC guidelines have also to take into account these. I would say these legalized or well established mechanisms of referral fee, discounts, or whatever. Because until if we have to really develop an enterprise of healthcare which is efficacious, affordable, and accountable, I think we have to move from sheer idealism to a bit of pragmatism. Otherwise, the binary gets too much into the fray that there are market of lemons, like, and very few credible and
Yes, yes, that's very important. And this is something
so
which is
one
very
of the Amazonian doctors, I'm forgetting his name, that he used to say that doctors have to charge for their consultation just like lawyers, because consultations have the core of it all. And just like
indeed.
in the judicial segment, you have senior lawyers and you have junior advocates. So perhaps the doctors on record, the GPs, they are the junior advocates who do all the spade work, and without them the seniors cannot function, and without the seniors the juniors, it's kind of a symbiotic relationship out there. There is nothing inferior, nothing superior. Everyone has chosen a place out there, like even the nurses have their place in the operational theater.
Wow, what a lovely point you've said. Every medical professional, every team player has a place in the entire system.
So I think that is where integral health comes into play. That is the core focus of the Future of Healthcare podcast. Dr. Surbi, thank you very much for reminding us on such a critical deficit in the India's public health system, where we are having huge brick and mortar, huge public and private investment, and still Arogyata is nowhere to be seen. The public trust in the entire healthcare system is still not very high. People, despite having huge money with them, they don't have the confidence that they have been treated efficaciously, affordably, and accountably. So somewhere or the other, these futuristic interventions, what you have propounded, and they all emanate from your very struggle, very tapas you have been undergoing for all these decades, out of your own singular passion. Somewhere I feel that these aphorisms, these learnings, they really reach at the policy level, and somewhere or the other, uh, the youngsters, the young medicos also start choosing to aspire to become a GP. That is a kind of a, you just need a small space, your medical knowledge to play, some computing gadgets to get connected with you to the entire network out there. And a doctor on record can really turn the tables around to really provide that efficacious, affordable, and accountable medicine. Thank you, Dr. Saab. We would be back again with yet another